common question we get asked is if you can cut off the liver and it'll regrow. The way to think of liver regeneration is that it doesn't necessarily grow as if you were to cut off a, leg off a starfish and then it's supposed to regenerate. The way to think of it is that each individual cell that's left over can then get bigger and hypertrophy the same way it would if you went to the gym and lifted weights. I am Dr. Alexandra Gangi, and I'm a surgical oncologist at Cedars-Sinai. I'm a primarily gastrointestinal surgical oncologist, so I deal with malignancies that are anywhere between the diaphragm and the pelvis. My personal interests are in managing gastric cancers, neuroendocrine neoplasms, hepatopancreaticobiliary neoplasms, and cancers that metastasize to the peritoneum and liver. GI cancers are cancers that arise in the gastrointestinal tract, so that can intrude anything in the esophagus, the stomach, the pancreas, the liver, the colon, the rectum. I elected to become a doctor because my grandmother actually had a type of cancer called a sarcoma. When I was young, she was very important to me, and in seeing other physicians treat her, I decided that it was something that I ultimately wanted to do, was to take care of patients and give them a chance at a normal life. In treating GI cancers, we essentially work together as a team. We have a multidisciplinary team of medical oncologists, surgeons, radiation oncologists, radiologists, and interventional radiologists who all work together to treat the patient's cancer. So when a cancer is localized, it essentially means that it's primarily in one area, usually where the primary site is. Depending on the type of cancer, sometimes that means you can go directly to surgery. Other times it means that you may benefit from getting some chemotherapy before going to surgery initially. Gastric cancer is one of the more common malignancies that we see worldwide, but it's not as frequent in the U.S., although we are seeing high numbers of patients who have gastric cancers. Typically, patients will present at an advanced stage, but for those patients who present with disease primarily in the stomach, one thing that's changed fairly significantly from about 10 to 15 years ago, a lot of these patients will frequently benefit from having some chemotherapy prior to having any type of surgical intervention. That really stems from research that we have from years ago that shows that patients typically don't tolerate chemotherapy after having a major operation to remove a majority of their stomach. And it's really no different whether we use a minimally invasive or a large incision approach, primarily because we're removing an organ that stores food. And sometimes just by not having the ability to eat the same way, you lose a significant amount of weight, and the immediate post-operative period can sometimes be difficult for patients, which is why it's then hard to put them through the ringer and give them additional chemotherapy that sometimes is difficult to tolerate when they're already feeling weak. Minimally invasive surgery is a type of surgery that we are using more and more frequently, and it's something that we're able to use for a variety of types of cancers, including various GI malignancies. About 30, 40 years ago, we didn't really have as many options for minimally invasive surgery. We performed laparoscopic surgery less frequently and generally did it for less complex operations like appendectomies or removal of gallbladders for benign reasons. As we became more comfortable using minimally invasive surgery or laparoscopic surgery, we started using it for the management of various GI malignancies, for example, for colon cancers and stomach cancers. And then recently there's a new platform known as robotic surgery, which is something that we're using more and more frequently. So we're able to actually treat patients with minimally invasive approaches, which allows for patients sometimes to stay in the hospital for fewer number of days and have less post-operative pain. Historically, we did a majority of these operations open. Sometimes, however, it's not necessarily feasible to do it minimally invasively because of the size of tumor or the location. And so sometimes we still use conventional open approaches. The goal is really to get the cancer out. So if we can do that minimally invasively, then we do. And if we need to use an open approach or a large incision, then we do that as well. The surgeon is still performing the operation. The robot is just another tool that allows us to get more challenging angles and continue to do this in a minimally invasive approach. Not all surgeons perform minimally invasive surgery, but a majority are certainly moving that way and building up their armamentarium of minimally invasive skills so that they're able to perform certain surgeries laparoscopically or robotically. Again, I think the important thing to take away is that just because robotics and laparoscopy sounds really exciting, it doesn't necessarily mean that it applies to your tumor type and the surgery that you should have. But yes, there are surgeons who are specialized in robotic surgery and others who may not be. So surgical oncology is certainly changing. The management of all cancers essentially are changing with our new available immunotherapies, personalized medicine, and targeted therapies. Certainly I don't think any surgical oncologist, if you asked, would feel badly if we became obsolete in the next 30 years, because certainly we want our patients doing well. But I do think we're seeing fairly remarkable responses to certain cancer types to current immunotherapy and targeted therapy treatments that we have. And I think with the advent of personalized medicine, we're going to see better and better responses for patients who have a variety of cancers and especially advanced disease. So some of the things that are up and coming, we can make surgery more precise and better, improving our imaging modalities, preoperative imaging modalities, developing 3D printing of tumors in certain locations. For example, this is very helpful when we're operating in the liver because everyone's anatomy is just a little bit different. Being able to identify exactly what something looks like in its 3D format is something that's helpful. Areas of therapy where we're trying to identify the use of immunofluorescent agents, meaning either injecting into the bloodstream or injecting into the tumor and then using basically cameras that'll take up certain types of light that'll allow us to see the margin of the tumor, the edges of the tumor, or where tumor is not, so that we can do more precise surgery. I think the most important thing for me in meeting a new patient is to really empower them and provide them with all of the information they may need so that they can make the appropriate decisions in terms of which direction they'd like to take their care.